we're going to discuss about adenomyosis. And before we proceed with the main discussion, it's important to know about the anatomy of the uterus. So there are three main layers of the uterus, namely the endometrium. Endo means inner. So this is the inner layer. Myometrium. Myo means muscles. So this is the middle part. And the perimetrium, or the area surrounding the uterus or surrounding the perimeter of the uterus, hence the term perimetrium. So grossly, this would be the endometrium, which forms the inner layer of the uterus, and this is the myometrium, composed of muscles. Okay, so you would note here that it is the largest portion or the largest layer of the uterus composed of muscles. And histologically, this is the myometrium, and closely related to it would be the basal zone or the basalis layer of the endometrium. I repeat, this is the myometrium, and closely related to it would be the basal zone or the basalis layer of the endometrium. Okay? So to a more superficial layer would be the spongy zone and the compact zone, which are parts of the functional zone of the endometrium. Functional, or also known as the functionalis layer. Again, spongy zone, compact zone are layers of the functional zone. Okay, so it's termed as spongy because, as you can see, there are glands and stroma that resemble that of the sponge, which are like holes. Okay, as compared to the compact zone, which is more compact in appearance. And just to correlate with the menstrual cycle, this is the stratum functionalis, or the functionalis layer, which we mentioned earlier is composed of the compact and the spongy zone. Okay, and in response to estrogen during menstrual cycle, okay, this will develop blood vessels, and it will also begin to thicken, okay, in preparation for implantation. And with the addition of progesterone on top of estrogen, they will begin to develop an extensive vascular network, okay, and then it will further thicken, and then will eventually shed in the absence of fertilization and eventual implantation. Okay, so this will begin to shed. Meanwhile, you would take note of the stratum basalis. Throughout the menstrual cycle, it will remain constant despite the presence of estrogens and progesterones. Throughout the menstrual cycle, the stratum basalis remains constant, and it would only be the functionalis layer that would be responsive of the hormones. Now we proceed with the adenomyosis, or the topic, our main topic. So we just dissect the term. Adeno meaning glands. Meiosis or myo means muscle layer. So in simpler terms, there are glandular structures in the myometrium of the uterus. So according to Compregyne 7th edition, this is their definition. It's derived, adenomyosis is derived from aberrant glands of the basalis layer of the endometrium. So this was emphasized earlier. We mentioned that the basalis layer is closely related to the endometrium. So the glands we refer here would actually be the glands from the basalis layer of the endometrium. So these glands would actually go into the myometrium. They encroach into the myometrium of the uterus. So these glands from the basalis layer do not usually undergo the traditional proliferative and secretory changes that are associated with cyclic ovarian hormone production. I repeat, they do not usually undergo the traditional proliferative and secretory changes associated with cyclic ovarian hormone production. We mentioned in this previous slide that the stratum basalis, regardless of the stage, regardless of the stage of the menstrual cycle and regardless of the presence of hormones, would remain constant all throughout. So this explains why they do not undergo this traditional proliferative and secretory changes. It's because they do not actually respond to the hormones. Again, this this is the definition. There should be benign endometrial glands and stroma within the myometrium. Again, benign. So it's a benign condition, and it would not only be glands that are present but also stroma within the myometrium. So where are these glands coming from? It's from the basalis layer of the endometrium. So as you can see, this is the myometrium, which stains deeply pink as compared to the endometrium. And you would note that these are the glands from the basalis layer or from the deeper layer of the endometrium, and they would go or encroach deeply into the myometrium. There are also some glands here. Again, so these endometrial glands, they rarely undergo, again, the normal cyclic changes as the normal uterine endometrium. But, again, there's a but. According to the studies, it revealed that there are actually estrogen receptors and progesterone receptors in the tissue samples from adenomyosis. So this somewhat contradicts what we mentioned earlier. There are actually receptors for estrogen and progesterone in the tissue samples from adenomyosis. So what does this imply? Meaning, even the glands from the basalis layer can actually respond to the hormones, and hence they can bleed. So this explains the third bullet: bleeding may occur in these ectopic areas. So strictly speaking, this is the standard criterion for the diagnosis of adenomyosis. The endometrial glands and stroma should be present in more than 1 LPF, low power field, or approximately 2.5 millimeters from the basalis layer of the endometrium. We repeat, endometrial glands and stroma present more than 1 LPF or 2.5 millimeter from the basalis layer of the endometrium. To make it simpler, this is a low power objective, and this is a low power field, or more, one low power field, for example. So this is what you see. So this is the gland, and this is the myometrium. So even if you move this field, so for example, if you move this field, you could still see some endometrial glands in here. So that would already be satisfactory, or that would already satisfy our standard criterion for the diagnosis of adenomyosis. So we do not merely come up with the diagnosis of adenomyosis by just saying there are endometrial glands and stroma. Okay, so it should be more, these glands and stroma should be present in by more than 1 LPF, or approximately 2.5 millimeter from the basalis layer. Okay, so now there's also a reaction to the glands present in the myometrium. So in response, the myometrium will also increase in cell number. So the the muscle cells will also increase in cell number, and at the same time they will also hypertrophy, or they will increase in size, which will lead to a globular enlargement of the uterus. Again, so these reactions of hyperplasia and hypertrophy by the myometrium are actually a result of the endometrial glands and stroma present in the myometrium. So you can actually appreciate it here, the how the myometrium increased in size, okay, even causing an enlarged part here, thus the globular enlargement of the uterus. So there are two types of adenomyosis. One is diffuse type, and number two, focal or adenomyoma, which is actually self-explanatory. For the diffuse type, it's largely affecting the myometrium, meaning the glands are almost uh, always affecting the myometrium, as compared to a focal or an adenomyoma type, which only affects a portion of the myometrium. So since this one, diffuse type, affects a large part of the myometrium, then this will result to asymmetric enlargement. It is also not encapsulated, and it is also the more common type of adenomyosis. Both anterior and posterior walls of the uterus are affected, but posterior wall of the uterus is more affected than the anterior. Meanwhile, the focal type or the adenomyoma, or just a portion of the myometrium is involved, it would contain a pseudocapsule. So since only a part would be enlarging, so only a part of the myometrium would be reacting, would have a reactive myometrial hyperplasia and hypertrophy. So this will result to an asymmetric enlargement of the uterus. The pathogenesis of this condition is still unknown, but there are theories according to Compregyne that is associated with the disruption of the barrier between the endometrium and myometrium, as in dilatation and curettage. Again, to make it simpler, dilatation in curettage is a procedure where you would make use of dilators. So we want to dilate the cervix so that the curette can enter the endometrial cavity. Again, we make use of dilators to facilitate the entry of a curette. Okay, so this curette would be used to remove, since it can have sharp edges or smooth edges. This can be used to remove polyps, or this can also be used to remove a hyperplastic endometrium. So as in cases of a pre-malignant condition. So that's the indication of DNC. Or it can also be done for incomplete abortion. So we want to completely remove the remnants or the products of conception. Unfortunately, this is a blind procedure. We do not actually get to see how deep, we do not actually get to calibrate how deep do we scrape off that endometrium, up to that point that we may involve or we may disrupt the barrier between the endometrium and myometrium when we exert too much pressure. So that's one of the theories for the development or pathogenesis of adenomyosis. So the symptoms of adenomyosis are as follows: menorrhagia, dysmenorrhea, and dyspareunia. Menorrhagia, heavy menses. It's because on top of the functionalis layer shed off, there's also an additional ectopic or aberrant basalis glands in the myometrium. And this would also cause dysmenorrhea. It's because the glands are present in the myometrium, which is in their abnormal location, which could also explain the presence of dyspareunia. So the risk factors are as follows: late reproductive years and increased parity. Again, if we just base it on the theory of the performance of dilatation and curettage that would actually disrupt the barrier between the endometrium and the myometrium, this could actually explain it. Okay, so the late reproductive years, it is during these years that actually there's a higher risk of development of endometrial hyperplasia and other malignant conditions that would actually be an indication for a dilatation and curettage. And of course, with the increased parity, there would be a higher chances of having abortion with increased parity again. So that would also be another indication for dilatation and curettage. Hence, these are risk factors for the development of adenomyosis. And for the diagnosis, we mentioned it earlier, the strict criterion of findings of endometrial glands and stroma more than 1 lpf, or that's 2.5 millimeters from the basalis layer of the endometrium. So that's the strict criteria. But we just want to add that it's usually an incidental finding through examination of histologic sections of surgical specimens. Or in simpler terms, the uterus was already removed, and that's when you just come up with the diagnosis of adenomyosis. Okay, so we'll explain this later on. So serial slides to confirm the continuity of benign growth of the basalis layer of the endometrium and the myometrium. So the pathologist would be the one reading the sections, cut sections of the uterus, and on series of slides that there would be continuous findings of aberrant and basalis layer in the myometrium, then that would already be confirmatory for the pathologist. So we may also come up with a clinical diagnosis, but it would be a very difficult job to come up with this, since more than 50% of women are asymptomatic or with only minor symptoms. So the symptomatic cases are usually between ages 35 to 50, and that the severity of symptoms would correlate with the depth of penetration and the total volume of disease in the myometrium, or how much of the myometrium is involved. For the clinical diagnosis, again, we base it on symptoms. However, more than 50% are symptomatic, right? So it would be very difficult to make this clinical diagnosis. And the signs, there would be a 2 to 3 times diffusely enlarged uterus. Okay, diffusely enlarged uterus, it can be globular. There would also be tenderness immediately before and during menstruation. It's because of the responsiveness of the ectopic endometrial glands to estrogen and progesterone. However, will you make a diagnosis of adenomyosis? Barely, with the sole consideration of enlarged uterus. Of course, it's very difficult because there are several etiologies of an enlarged uterus, like a leiomyoma, like an endometriosis. Hence, a clinical diagnosis is actually very difficult to make. There are also risks for pregnancy complications with adenomyosis, like premature labor and delivery, low birth weight, and a premature preterm rupture of membrane. So this can all be attributed to the mass effect, or to the enlarging myometrium as a result of the ectopic endometrial glands. Okay, so this will actually contribute to the size on top of the fetal size, hence the low birth weight due to the compression effects, and also due to the contributory size of the adenomyosis. This may also result to premature labor and delivery and a premature preterm rupture of membranes. So now, should we make a diagnosis clinically or histologically? Okay, so many times it is diagnosed retrospectively following a hysterectomy for other indications. I repeat, many times it is diagnosed retrospectively following a hysterectomy for other indications. Again, retrospectively, meaning the uterus has been removed, and that's when we only make a diagnosis of adenomyosis. And actually, the hysterectomy is done for other indications, not for adenomyosis. So it's quite too much to digest, but again, I repeat, the hysterectomy was done for other indications, for other more urgent indications other than adenomyosis. Since we mentioned earlier, more than 50% of patients would be asymptomatic, okay? And also, adenomyosis may coexist with both endometrial hyperplasia and endometrial carcinoma. Again, we mentioned earlier that adenomyosis is more common among elderly, and at the same time, it may coexist with these two conditions, which are a lot more severe than adenomyosis. Hence, this would be the indications for hysterectomy. and not adenomyosis. Okay? So two of three women with adenomyosis have a coexisting pelvic pathology. Number one is myoma, which would also produce pressure symptoms. So these are actually indications for a hysterectomy. And during the pathologic examination or histologic examination by the pathologist, there would be an incidental finding of endometrial glands and stroma, more than 1 lpf or 2.5 millimeter from the basalis layer of the endometrium. So that's when the diagnosis actually of adenomyosis is done. So there are attempts to establish a preoperative diagnosis, but there was no success because of a very low sensitivity for it to be of practical value, like transcervical needle biopsy of the myometrium. So that's it for our discussion of adenomyosis. Our main source is Comprehensive Gynecology 7th edition. Thank you.